Hello and welcome back everyone. So continuing our discussion about the airway management video playlist, in this video we will talk about the rapid sequence intubation. So the rapid sequence intubation, the RSI, include a simultaneous administration of an induction agent and a neuromuscular blocking agent to facilitate orotracheal intubation. And the RSI is a technique indicated when rapid control of the airway is required in cases of acute respiratory failure due to inadequate oxygenation or ventilation, and in cases of airway protection in patients with altered mental status. When the Glasgow Coma Scale is 8 or below, that is when the patient can't protect their airway, so intubation is required to protect the airway for them. And the RSI is also indicated in acute upper gastrointestinal bleeding with a high risk of aspiration. Now, in preparation for this procedure, the airway risk assessment should be done before the procedure, and this will be explained in a little bit, and also positioning of the patient. There should be a good understanding of the anatomy, also selection of the endotracheal tube size and the blade size also, and all other necessary supplies must be available at the bedside, including alternative options to secure the airway in case of failure, like the surgical airway or the extraglottic airway, and a checklist is very helpful in these situations. So first, let's talk about assessment of the airway risk. So the airway risk assessment should be done to determine if an airway will be difficult or not, and that should be done before the procedure, and multiple mnemonics can be used. A popular one is Lehane. So the L in Lehane is for look, so you look externally, looking for facial trauma, beard, loose teeth, dentures, and large incisors. And all of these factors indicate a difficult airway. Now the E in Lehane is for evaluation of the 3-3-2 rule. And the 3-3-2 rule is about that. First, can 3 fingers fit between the incisors? And can 3 fingers fit between the tip of the chin and the hyoid bone? And can 2 fingers fit between the top of the thyroid notch and the hyoid bone? And a decrease in these distances can be an indication of a difficult airway. The M in Lehane is for the Malambaty score, and Malambaty assesses how much of the posterior pharynx and uvula can be seen when you ask the patient to open their mouth as hard as they can. And a higher Malambaty score indicates a more difficult airway. So Malambaty score 1 indicates that the entirety of the uvula can be visualized, such as you can see in this picture here. And Malambaty score 2 indicates that half of the uvula can be visualized, such as you can see in this picture here. And Malambaty score 3 indicate only the base of the uvula can be visualized, such as you can see in this picture here. And Malambaty score 4 indicate that the uvula cannot be visualized, such as you can see in this picture here. Now the O in Lehane is for obstruction or obesity, and obesity, when the body mass index is higher than 30, can predict a difficult airway, and obstruction of the airway, including head and neck cancer and epiglottitis, can indicate a difficult airway. And the N in Lehane is for neck mobility, so you have to assess the neck mobility, and a neck that cannot be maneuvered into an ideal position due to trauma or a C-collar that is applied or due to rigidity, this can lead to a more difficult airway. Now, in preparation for rapid sequence intubation, we also have positioning. So, in positioning, the neck should be flexed at the lower cervical spine, which is the C6, C7, and extended at the upper C-spine, which is the C1, C2 vertebrae. And that is what we call the sniffing position. And the sniffing position allows for the best visualization of the anatomy, including the epiglottis and the vocal cords, such as you can see in this picture here. You also have to be familiar with the anatomy. So the epiglottis serves as the primary landmark that will direct successful endotracheal intubation. And the origin of the epiglottis can be found at the base of the tongue, and the valley between the tongue and the epiglottis is called the vallicula. So as you can see in this picture here, this is the epiglottis, and this is here the tongue, and between the epiglottis and the tongue we have the vallicula. So this is here is the vallicula. Now, when intubating with a laryngoscope, the tip of the blade should ideally be placed at the base of the tongue in the vallicula, and a ventral and inferior movement of the blade reveals the vocal cords, and that is where the tube is inserted. So again, here's the vallicula. So the tip of the laryngoscope blade should be placed in here, and that is referring to the Macintosh blade, because if we are using the Miller blade, it would sit over the epiglottis like that. But the Macintosh blade would sit in here, and then ventral and inferior movement would reveal the vocal cords here, and that is where the tube is inserted. Now let's talk about the modified Cormack and Lehane. So the modified Cormack and Lehane grading system allows the physician to evaluate their view of the vocal cord and estimate the chance of successful intubation. So the modified Cormack and Lehane grading system consists of 4 grades. So in grade 1 you can see a full view of the glottis, as you can see in this picture here, and that is seen in 70% of patients, and the likelihood of difficult intubation in these patients is less than 1%, because you can see the vocal cords, so you can insert the tube directly at them, and it is hard to miss the trachea in this grade. In grade 2 we have 2 types, A and B. In grade 2A you see a partial view of the glottis, and that is you can see in 20% of patients, and the likelihood of difficult intubation is 8%, and grade 2A is on this picture here. In grade 2B, only the posterior extremity of the glottis can be seen, or only the arytenoid cartilage can be seen, and that is in 5% of patients, and the likelihood of difficult intubation is around 65%. Now in grade 3, only the epiglottis can be seen, and none of the glottis can be seen, and that is in 1% of patients, and the likelihood of difficult intubation is around 85%. And grade 3 you can see in this picture here. And then in grade 4, neither the glottis nor the epiglottis can be seen, and this is very rare you can see in a patient, and the likelihood of difficult intubation is very likely, as you can see in this picture here. Now regarding the endotracheal tube size, so for adults, for females, it's 7 to 7.5 millimeters of diameter, and in males it's 7.5 to 8 millimeters. In pediatrics, for the uncuffed tubes, you have to follow this formula. So you divide the age in years by 4, and you add 4 millimeters. So if the child ages 4, you divide 4 on 4, and that is 1, and you add it to 4, so it would be 5 millimeters. And for the cuffed tubes, you divide the age in years on 4, and you add 3.5 millimeters. So if the child age is 4, then it would be 1 plus 3.5, then it is 4.5 millimeters. Regarding the blade selection, so the most commonly used laryngoscope blades are the Macintosh and the Miller blades. So the Macintosh blade has a curved spatula that should be placed inside the valvula, and it is used to approximate the curvature of the tongue and move the epiglottis, the mandible, the hyoid, and other soft tissues out of the view of the glottis. And multiple sizes available for the Macintosh, and you can see it right here on this picture. So it has a curved spatula. The Miller blades, on the other hand, is a flat spatula designed to go over the epiglottis to reveal the vocal cords, and multiple sizes available too. So you can see the Miller blades right here. Now let's talk about the induction agents. So the induction agents are administered via rapid intravenous push to induce anesthesia, which is unconsciousness, and options for induction agents include etomidate, which is dosed as 0.3 milligrams per kilograms, and etomidate has a minimal effect on the cardiovascular system and the respiratory system, and it decreases intracranial pressure, and this is what most commonly used nowadays. We also have the ketamine, which is dosed as 1 to 2 milligrams per kilograms, and ketamine increases heart rate and blood pressure, and this is more suitable in trauma patients who are bleeding, and it also leads to bronchodilation, and it increases intracranial pressure. And we also have the propofol, which is dosed as 0.5 to 1.5 milligrams per kilograms, and propofol decreases heart rate and blood pressure, which is opposite to ketamine, and it causes the most respiratory depression out of the 3 agents. And since the induction agent has a specific half-life at which the drug stops working, then the anesthesia must be maintained using inhaled volatile liquids. And options for these liquids include the sevoflurane, the desflurane, and the isoflurane. Now regarding the paralytic agents, so after administration of an induction agent, the paralytic agent should be administered, and options include the succinylcholine, which is administered at 1 to 2 milligrams per kilogram, and the succinylcholine has an ultra-rapid onset and offset, which is ideal for rapid sequence intubation, but it is very risky in patients with hyperkalemia, such as in patients with burns, trauma, and neuromuscular diseases, and it may cause malignant hyperthermia, and it may cause bradycardia and increases the intracranial pressure. We also have rocuronium as an option, which is dosed as 1 to 1.5 milligrams per kilogram, and it has an onset that is a little bit delayed, which is around 60 seconds after administration, while the succinylcholine would work after 30 seconds of administration. But the rocuronium has a minimal cardiovascular side effects, and it has no risk for malignant hyperthermia, and it is much more safe in general. That is why the rocuronium and the other non-depolarizing muscle relaxants are more commonly used nowadays. Now let's talk about the technique. So patients, supplies, and team must be properly prepared. Induction agents can be administered to the patient first, followed by the paralytic agent, and the bag valve mask should be utilized to pre-oxygenate the patient as much as possible with 100% oxygen, and the positive pressure ventilation can be used also to pre-oxygenate the patient. And after allowing the paralytic agent to take effect, which is after 60 seconds, place the patient in a sniffing position and open the mouth with the scissoring technique. Now the scissoring technique involves placing the right thumb on the right middle finger and inserting the right hand into the patient mouth. And the physician then scissors the patient mouth open, crossing the thumb and the middle finger, and this is explained in a video linked in the description of this video. And the laryngoscope should then be inserted into the patient's mouth with a sweeping motion from right to left, moving the tongue out of the view. And this is also explained in a video linked in the description. And then the clinician should locate the epiglottis and place the laryngoscope in the vallecula, and a ventral and inferior motion should be performed with a rigid wrist without abduction or rocking of the wrist. And suctioning can be performed to obtain a better view and clear the debris, and pressure can be applied to the thyroid cartilage to manipulate the glottis into view. So external pressure can be applied to the thyroid cartilage to obtain a better view, and once the clinician can locate the glottis, the endotracheal tube can be passed through the vocal cords, and once passed, the stellate can be removed and the tube should be advanced based on the Chula formula. And the Chula formula states that the endotracheal tube depth should be 0.1, the height in centimeters, and +4. And the Chula equation will give the depth at which the endotracheal tube should be advanced when measured at the patient teeth. So you start measuring from the patient teeth downward. Now the cuff should be inflated after the tube is advanced to the proper distance, and end-tidal capnography and bilateral lung sounds should all be used to verify the placement initially, and a chest X-ray should be performed to assure adequate placement. Finally, let's talk about the contraindications to the rapid sequence intubation. So the absolute contraindications include complete upper airway obstruction and loss of facial or oropharyngeal landmarks, and in this case it will require a surgical airway to be placed. And relative contraindications include injuries to the airway and anatomic abnormalities and proficiency of the clinician. And the relative contraindications can be evaluated using the Lehane, mnemonic, and the Cormack and Lehane grading system discussed already. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe.